Welcome to the deep dive, where we take your sources, unpack them, and really try to pull out those critical insights, those aha moments that, help you stay informed.
That's the goal.
Today, we're diving deep into something really fundamental in clinical practice. This is a specific admission protocol designed for patients who are scheduled for elective vascular surgery.
Right.
Our source material comes from a real-world setting. It's excerpts from a protocol document used at the Vascular and Hyperbaric unit at Eugene Rice Hospital, detailed by Dr. Gregory Weir, a vascular surgeon there.
And for you listening, as a specialist clinician dealing with the complexities of patient care every day, this isn't just about, reading through a checklist.
Oh, not at all.
This is a chance to really dissect the why behind every single instruction. We're going to dig into the clinical thinking, the specific risks we're trying to mitigate, especially in a vascular context, and how these steps really represent accumulated best practice and experience.
Yeah, think of this document almost like a detailed map, guiding a patient safely from the very moment they arrive on the ward right through to the threshold of the operating theater.
Exactly. It's a pathway.
So our mission today is to walk through this protocol step by step. We want to understand the clinical significance, the practical implications of each point, almost like we were, getting ready to implement this ourselves or maybe refine it. We'll follow the structure of the source document, starting with patient arrival, moving through all the necessary checks, the preparations, and then finishing up with that crucial handover to the operating room.
And every instruction, it's there for a reason. It's a layer of safety or maybe efficiency. We're going to peel back those layers and try to understand the clinical decisions that are sort of embedded within this protocol.
Okay, let's get started then. Let's unpack this, beginning right at the very start with Section 1, Patient Identity. Point 1.1, it seems basic, but it's foundational. Confirm patient identity on arrival in the ward or unit. Hospital sticker, verbal confirmation, family. Why is this placed right at the very beginning? What makes it so non-negotiable?
Well, it's the absolute cornerstone of patient safety. I mean, before you do anything else, before you draw blood, give a medication, certainly before you perform a procedure, you must be certain who your patient is.
Right.
Preventing wrong patient errors is just paramount. A mix-up, especially in surgery, it's catastrophic. It can be irreversible. So this is, the fundamental first layer of safety in what really needs to be a multi-layered system.
And the protocol is specific. It mentions a multimodal approach,
Yeah.
the hospital sticker, verbal confirmation, and family. Why use multiple methods? Isn't one enough?
Relying on just a single point of identification, it just introduces an unacceptable level of risk. Checking the hospital sticker or the wristband, that's standard practice, of course.
Yeah.
You should be verifying the patient's full name, their date of birth, or unique hospital number against your documentation.
Okay.
But, bands can be misapplied. They can be misread. They can even, in rare cases, be accidentally swapped between patients. So you absolutely need independent verification beyond just the band.
Which I guess is where the verbal confirmation comes in. How should that ideally be done?
Yeah.
To be really effective?
Yeah, and this is crucial. It's not just asking, are you John Smith? The best practice, and what verbal confirmation really implies in a safety-conscious setting like this, is asking open-ended questions.
Yep.
Yes, like, can you please state your full name for me? And what is your date of birth? By making the patient actively state the information, you ensure they're alert enough to respond correctly and that they're providing the information themselves. They're not just, passively agreeing to what you've said, which a drowsy or confused or even just an anxious patient might do reflexively.
That's a really important distinction. You're getting them to generate the information, not just confirm it.
Exactly. You're independently verifying, not leading them. And then the third element, involving the family, that's key for those situations where the patient can't reliably participate in that verbal check.
Like minors, maybe.
Minors, exactly. Or patients with cognitive impairment, significant language barriers, or maybe those who are acutely unwell or already sedated. Family members can provide that crucial confirmation when the patient simply cannot. It adds another important layer of security.
You can just picture it, can't you? A busy ward. It might be easy to just glance at a band, say the name, get a nod, and assume it's confirmed.
Right.
So this multimodal approach, especially that open-ended verbal confirmation, it's specifically designed to stop that single point of failure.
Think of it like sequential locks on a high-security vault. The hospital band, that's one lock. The patient actively stating their identity, that's the second lock. And family confirmation, that's like a third backup lock. All of them really need to be engaged to make sure you have the correct individual before you even think about, opening the vault of medical care for them.
That really clarifies the profound importance behind what looks like a simple first step. Okay, now, point 1.2 shifts focus a bit. Welcome the patient and family and assure them that we are honored to help the patient. This isn't a technical safety check. Why include this?
This point is critical because it explicitly brings the human element into the clinical process. While identity verification prevents errors, welcoming and reassuring the patient addresses their emotional state, and that's incredibly important in the preoperative period.
Yeah, people are often very anxious.
Hugely anxious. Elective surgery, even for conditions that might seem routine to us, it's a source of significant anxiety for most people, and for their families, too. There's fear of the unknown, concern about the procedure itself, the recovery, the outcome.
Patients arrive feeling quite vulnerable, I imagine.
Precisely. So a warm, respectful welcome, and using that specific phrase, "we are honored to help," it immediately starts to build trust. It sets a positive, caring tone for their entire experience. And this isn't just about, being polite. A patient who feels welcomed, respected, safe, they're generally more relaxed, they're more likely to cooperate with instructions like fasting or needing to mobilize later, and their overall perception of the quality of care is significantly enhanced.
And does that reduced anxiety actually have any tangible clinical benefits before the surgery?
Yeah. Well, it potentially can. Extreme anxiety can trigger physiological stress responses, things like elevated heart rate, higher blood pressure. While that's probably not the primary reason for this step, promoting a sense of calm certainly doesn't hurt in terms of having more stable baseline vital signs leading into anesthetic induction.
Okay.
But more fundamentally, though, it's really about acknowledging the patient as a person, not just, a case number or a procedure waiting to happen. It elevates the protocol beyond just a technical checklist to actively include compassionate care as an essential element right from the start.
So it's about establishing that therapeutic relationship immediately, building that trust that's really foundational for everything else that's going to follow.
Exactly. Safety and compassionate care right from the outset. Those are the initial dual focuses here.
Okay, so that gives us a really clear picture of those crucial initial steps upon arrival. Let's do a quick micro recap of section 1. So we've established that patient identity verification is the absolute non-negotiable first step, using multiple methods, the sticker, open-ended verbal confirmation, and family input when needed to prevent catastrophic errors.
The sequential locks.
The sequential locks, exactly. And paired with that is the vital human element, welcoming the patient and family warmly to reduce anxiety, build trust, and set a positive tone, acknowledging them as individuals. Safety and compassion, hand in hand the moment they walk in.
Perfectly summarized. That's the foundation.
All right, let's move into the realm of clinical assessment now, starting with section 2. Blood tests, which specifically references Lancet Laboratory. Point 2.1 simply says, routine bloods as per Lancet protocol.
Okay, so this immediately tells us there's a standardized panel of tests being ordered, and they're processed by a specific external lab, Lancet in this case. Now, we don't have the full Lancet protocol in front of us, but we can certainly talk about the typical components of routine bloods in a preoperative workup for elective surgery. Especially relevant for vascular patients who, as you know, often come with a complex medical history.
Right, they often have multiple comorbidities. So what are the kind of must-have components you'd expect in a routine panel for this specific population?
Well, first off, a full blood count, or FBC, is absolutely essential. This checks the red blood cell count and the hemoglobin level. That's crucial for spotting any anemia, which impacts the blood's oxygen carrying capacity pretty significant in patients who might have underlying cardiopulmonary issues and are about to undergo surgery.
Makes sense.
The FBC also gives you the white cell count, which screens for any potential hidden infection, and critically, the platelet count. Platelets are vital for clotting, so assessing their number is highly relevant in vascular surgery where, meticulous hemostasis is absolutely required.
Okay, so assessing the blood components, red cells, white cells, platelets. That makes perfect sense. What about the chemistry side of things?
Yes, the chemistry panel is critical. Electrolytes and renal function tests are standard. Sodium, potassium, urea, and creatinine. Imbalances, particularly in potassium, can seriously affect cardiac function and rhythm, a major concern in vascular patients who are often prone to cardiac disease. Sodium levels are important for fluid balance, too.
And the kidney function.
Yeah.
Urea and creatinine.
Absolutely vital. Urea and creatinine give you a snapshot of how well the kidneys are working. Vascular disease is often systemic. It can affect the renal arteries, so some degree of renal impairment is unfortunately common in these patients. Knowing their kidney function is crucial because it influences how you manage fluids, how you dose medications that are cleared by the kidneys, including some anesthetic agents and post-op pain relief, and it flags a potential risk if contrast media might be needed during or around the time of surgery.
Right. Contrast-induced nephropathy is a real concern there. So you're getting a handle on kidney function and electrolyte balance.
Precisely. Liver function tests, LFTs, are also typically part of the routine panel. They assess things like protein synthesis, albumin levels, for instance, and the liver's overall metabolic and excretory capacity. That's important for drug metabolism and just gives you a picture of overall systemic health. And glucose. Blood glucose level is vital given the very high prevalence of diabetes in patients with atherosclerosis. Preoperative hyperglycemia, high blood sugar, needs to be identified and managed because it's known to increase the risk of surgical site infections and can impair wound healing.
And what about clotting status beyond just the platelet count?
Oh, absolutely non-negotiable in vascular surgery. Coagulation studies, that's usually the prothrombin time, PT, the activated partial thromboplastin time, APTT, and the international normalized ratio, INR, are essential. These tests assess the complex cascade of clotting factors. Knowing the patient's baseline clotting ability is critical, especially if they're taking anticoagulant medications like warfarin or the newer direct oral anticoagulants, or antiplatelet agents like aspirin or clopidogrel. This directly informs their risk of bleeding during and after the procedure.
So the clinical rationale for this whole standard panel seems pretty comprehensive then. It's about establishing baseline function across key organ systems, identifying risks that might be correctable, and really informing the planning for both surgery and anesthesia.
That's exactly it. It's about building a foundational physiological profile before you proceed. Can we perhaps optimize their hemoglobin if they're anemic? Are their electrolytes balanced, particularly potassium? Are their kidneys and liver functioning well enough to handle the stress of surgery and the drugs involved? Is their clotting status appropriate for operating on major blood vessels? These routine tests provide the essential data points to answer those key questions and hopefully mitigate preventable risks before they become problems.
Let's try a scenario based on this, maybe like a board-style question. Imagine the routine bloods for a patient who's booked for an elective femoral popliteal bypass, a common vascular procedure, come back showing significantly elevated creatinine and urea. What's the immediate clinical implication of that finding, and how might it affect the surgical or anesthetic plan based on typical pre-op principles?
Okay, that's a great scenario. Those elevated creatinine and urea values immediately wave a big red flag for potential renal impairment, right? The immediate clinical implication is that this patient has reduced kidney function. This significantly increases their overall perioperative risk, not just for further kidney problems, but cardiovascular complications are often linked too.
So it affects more than just the kidneys.
Definitely. Now, for the surgical plan itself, it might not change the actual anatomy of the bypass, but the surgeon is now acutely aware they're dealing with a patient at higher risk of fluid shifts, possibly slower recovery, but where it really hits is the anesthetic plan.
How so?
Renal function heavily dictates how drugs are cleared from the body. The anesthetist will need to be extremely careful in selecting and dosing their anesthetic agents, muscle relaxants, and post-operative painkillers. They'll likely choose drugs that are less reliant on kidney excretion or adjust doses significantly to avoid drug accumulation and prolonged effects. And if there was any thought of using intraoperative angiography with contrast dye, the risk of contrast-induced acute kidney injury just shot way up. So they'd be thinking about aggressive prehydration strategies, maybe using lower osmolar contrast, minimizing the dose, or even trying to avoid contrast altogether if possible. This finding would absolutely trigger an immediate discussion between the surgeon and the anesthetist. And depending on how high those numbers are and whether it looks like an acute issue or chronic disease, it might even lead to postponing this elective case to investigate further or try and optimize the patient's renal status first.
Oh, wow. That scenario really drives home why these routine tests are anything but minor. They are absolutely essential tools for risk stratification and detailed planning.
Exactly right. They're really the required minimum data set to proceed safely with elective surgery in this patient group.
Okay, let's do a quick micro recap for Section 2. We've discussed the importance of routine preoperative blood tests, as referenced by the Lancet protocol in this case. The goal is to establish that baseline physiological status, checking blood counts, kidney function, liver function, electrolytes, glucose, and coagulation to identify any underlying issues or risks before the patient goes under the knife, allowing for optimization and safer planning.
Well put. It's the pre-flight check for the patient's internal systems.
Okay, we've covered the essential baseline blood work. Now, Section 3 deals with other investigations, and it specifically states CXR, duplex Doppler, MRA, CTA should only be done at the specific request of Dr. Weir. Now, these are all investigations we commonly associate with vascular workups. So why are they not routine on admission? Why do you need a specific request from the surgeon?
Yeah, this point really highlights a principle of focused, value-based care, especially in that immediate preoperative phase. The key thing to understand is that these investigations, chest X-ray, duplex ultrasound, MRA, CTA, they're typically part of the diagnostic process that happens before the decision for elective surgery is even made.
Right, they're done in the workup phase.
Exactly. The assumption baked into this protocol is that the surgeon has already reviewed the necessary imaging to confirm the diagnosis, assess the extent of the disease, map out the anatomy, and plan the specific procedure they intend to do. Ordering them again on admission implies there's a very specific, usually quite defined, clinical question that needs answering right before the patient goes to theater.
Okay, let's break that down. Why might each one be specifically requested right at admission? Let's start with the chest X-ray, the CXR.
Okay, a chest X-ray, as you know, gives us information about the lungs and the heart size and shape. It's not universally required for all surgeries, especially less complex ones in patients who are otherwise reasonably healthy. So why only on specific request here? Primarily to avoid unnecessary radiation exposure for every single patient.
Makes sense. When would it be requested then?
It would likely be requested on admission if a patient presents with new or worsening respiratory symptoms like shortness of breath or a cough, or if they have a known history of significant lung disease like COPD or pulmonary fibrosis. Also, for patients with known significant cardiac issues, the surgeon might want a fresh look to check for signs of pulmonary congestion, fluid overload, or significant changes in heart size, cardiomegaly. And finally, it's often requested before major procedures like aortic surgery, where postoperative pulmonary complications are a known higher risk. An abnormal finding on that admission CXR could lead to interventions to optimize their respiratory function before surgery, or perhaps alter the plan for postoperative care, maybe necessitating a higher level of monitoring.
So it's really driven by specific patient factors that raise concern, or the complexity of the planned surgery, rather than being a default check for everyone.
Correct. It's targeted. Okay, next on the list is duplex Doppler ultrasound. This is a non-invasive test using sound waves to visualize the blood vessels and, importantly, assess blood flow patterns. It's a primary diagnostic tool for identifying blockages, stenosis, aneurysms, that sort of thing.
But again, the protocol says only on specific request when they're admitted.
Right. And the reasoning is similar. The diagnostic duplex scan, the one that identified the problem needing surgery in the first place, should ideally have been done well before the patient gets admitted. Requesting another one right on admission would be for very specific, often time-sensitive reasons.
Such as?
Well, perhaps the patient's symptoms have changed dramatically since their last scan. Maybe they've developed sudden worsening pain or numbness that might warrant a reevaluation of the vessel anatomy or flow right before surgery. Or the surgeon might need very precise vein mapping just prior to the operation if they plan to harvest a vein, like the saphenous vein from the leg, to use as a bypass graft. A duplex can map out the vein's course and diameter.
Ah, okay, for graft planning.
Yes. Or it could be simply to confirm a specific anatomical landmark or check the patency, the openness of a particular vessel segment immediately before heading to theater. It's really about refining the immediate surgical plan based on the very latest information or reassessing if there's been a significant clinical change rather than making the initial diagnosis all over again.
So the main diagnosis is already established. This admission request would be more about optimizing the surgical approach based on the absolute latest information available just before starting.
Exactly. Then we have the big guns. MRA and CTA, magnetic resonance angiography and computed tomography angiography. These are the advanced cross-sectional imaging techniques that provide those detailed, often three-dimensional views of the blood vessels.
And these are usually the definitive preoperative mapping tools for planning complex vascular surgery, aren't they?
They often are, yes. They provide the detailed roadmap the surgeon needs. MRA uses magnetic fields. It's great for soft tissue detail, avoids ionizing radiation, but it can take longer, sometimes requires contrast, and has contraindications like certain metal implants or pacemakers. CTA uses X-rays and usually requires intravenous iodine-based contrast. It gives excellent spatial resolution, shows calcification in vessel walls really well, but it involves radiation exposure and carries that risk of contrast-induced nephropathy we mentioned, which is a significant concern for many vascular patients who might already have some kidney impairment.
Okay, so given they provide the roadmap, why would they only be requested on admission rather than being routine?
Because, again, these are resource-intensive investigations, they're expensive, they take time, and they have potential risks. Like the duplex, the definitive preoperative MRA or CTA that was used to plan the surgery is expected to have been done already, likely weeks or months before admission. Requesting one on admission implies a very significant, specific, and often urgent need. Perhaps the previous images are considered outdated because too much time has passed, or there's a strong suspicion of an acute change in the patient's condition, like a suspected clot extension. Or maybe it's for planning an extremely complex reconstruction, where the surgeon feels they absolutely need the very latest, highest resolution imaging just hours before the operation starts.
It sounds like for all these other investigations, CXR, duplex, MRA, CTA, the underlying principle is that the standard necessary workup has been done and reviewed before the patient is admitted for their elective procedure. Needing them again right on admission is the exception, not the rule, and it has to be driven by a specific immediate surgical requirement or a change in the patient's status.
That is precisely the principle at play here. It's about using these powerful diagnostic tools judiciously. It avoids unnecessary patient exposure to radiation or contrast agents, reduces costs, and ensures that any investigations ordered immediately before surgery are directly tied to refining the final plan or addressing a new, pressing clinical concern. You could think of these as being on the surgeon's special request menu, not the standard daily special. They're ordered only when there's a specific, well-defined clinical need identified by the operating surgeon right at the time of admission.
That surgeon's special request idea helps make it clear. They aren't part of the standard admission package unless specifically added for a reason.
Correct. They are specific additions, each with a defined purpose.
Okay, let's do a quick micro recap for Section 3. We've clarified that specialized investigations like chest X-rays, duplex ultrasounds, MRAs, and CTAs are not part of the routine admission protocol here. They're performed only when specifically deemed necessary and requested by the surgeon. This reflects a value-based approach, avoiding unnecessary tests and radiation or contrast exposure, assuming the main diagnostic workup is complete pre-admission. These are ordered only to answer specific, immediate clinical questions relevant to the final surgical plan or a change in patient condition.
Well summarized. Judicious use of resources based on specific need.
All right, let's transition now to Section 4, Patient Preparation for Surgery. This section is quite detailed, listing numerous steps that need to happen before the patient goes to theater. Point 4.1 is crucial. The patient must remain nilled per mouth from admission until surgery.
Yes, this is absolutely non-negotiable preoperative safety. Nil per mouth, or NPO, status is the primary way we prevent pulmonary aspiration. That's the inhalation of stomach contents, food, or liquid into the lungs during anesthesia.
Pulmonary aspiration. You mentioned earlier it's a potentially fatal complication.
It absolutely is. During anesthetic induction, and sometimes during maintenance or emergence, the patient's protective airway reflexes, like coughing and swallowing, are suppressed or absent. If there's anything significant in the stomach, it can easily be regurgitated and then aspirated down into the trachea and lungs. This can lead to severe chemical pneumonitis, bacterial pneumonia, acute respiratory distress syndrome, ARDS, and in the worst cases, death. Ensuring the stomach is empty, or as empty as possible, is therefore paramount.
And that this protocol is quite strict. It specifies from admission, which might be different from some standard time-based fasting guidelines people are familiar with.
Yes, that's an important distinction. Standard guidelines often specify minimum fasting times based on the type of intake, for example, maybe 6 to 8 hours for solid food, perhaps 4 hours for milk, and 2 hours for clear liquids like water or black coffee. This protocol simplifies it, likely for logistical clarity and maximum safety on the ward. From the moment the patient is formally admitted to this specific unit, they are NPO. Full stop. Okay. This eliminates any ambiguity about when they last ate or drank at home, maybe misremembering times, and ensures a guaranteed minimum fasting period. Now, for patients admitted the day before surgery or admitted early in the morning for a surgery scheduled later in the afternoon, this could mean quite a prolonged fasting period. That needs to be managed from a comfort perspective. Things like good oral care become important.
So, non-compliance here. If a patient admits to eating or drinking after admission, has direct, critical implications for the anesthetic plan.
Oh, absolutely. Any significant noncompliance with NPO status must be communicated to the anesthetist immediately. They need to know. Depending on what was consumed and when, they might have to delay the surgery or, in some cases, cancel the elective case for that day. Alternatively, if the surgery must proceed urgently, they would likely need to adapt their anesthetic technique, often using what's called a rapid sequence induction, which involves specific drugs and maneuvers to secure the airway as quickly as possible after inducing unconsciousness, minimizing the time the airway is unprotected.
And the physiology matters, too.
Yes, the physiology is relevant too. Things like stress, anxiety, pain, and certain medications, like opioids, can actually delay gastric emptying. So even if a patient followed standard fasting times, their stomach might not be truly empty, making strict adherence to the NPO rule even more important in this preoperative setting.
Okay, NPO is critical. Point 4.2. Apply an oxygen mask. 40% O2 mask at 5 millimeters. Why are we putting oxygen on these elective vascular patients before they even get near the theater?
This is about pre-oxygenation. It's a standard and very important practice before anesthetic induction, especially relevant, as you say, in vascular patients who often have underlying cardiopulmonary issues or systemic atherosclerosis, which might limit their reserve. What you're doing is maximizing the oxygen levels within the patient's lungs before anesthesia begins.
How does that work? You mentioned an oxygen reservoir.
Yes, exactly. You're essentially washing out the nitrogen that normally makes up about 79% of the air in the lungs, specifically in the functional residual capacity, the air left after a normal breath out, and replacing it with as close to 100% oxygen as possible. This creates a much larger store or reservoir of oxygen within the lungs.
And why is that reservoir useful?
Because when anesthesia is induced, and before the anesthetist has secured the airway definitively, usually with an endotracheal tube or a laryngeal mask airway, there's typically a period where the patient stops breathing spontaneously, a period of apnea. This oxygen reservoir provides a crucial buffer. It significantly extends the time before the patient's blood oxygen saturation, CPO2, begins to fall. This safe apnea time is really valuable, giving the anesthetist more time to manage the airway safely. And as we said, this is particularly beneficial for vascular patients who might have less physiological reserve and could desaturate much more quickly than a younger, healthier individual.
Okay, pre-oxygenation makes sense. What about the specifics here? A 40% mask, why not 100%? And why greater than 5 liters per minute flow?
Good questions. While the goal is to get the oxygen concentration as high as possible, achieving a true 100% usually requires a tight-fitting mask with a specific valve system, often actively applied by the anesthetist just before induction. This protocol specifies a 40% mask for the ward setting. This might be a Venturi mask set to 40%, or more commonly, a simple oxygen mask, like a Hudson mask. A simple mask, run at an adequate flow rate, can deliver around 40–60% inspired oxygen concentration. It's a practical way to deliver a significantly higher oxygen level than room air, which is 21% reliably on the ward.
And the flow rate, greater than 5 liters per minute.
The flow rate is critical, especially if using a simple mask without a reservoir bag. It's primarily to prevent the rebreathing of exhaled carbon dioxide, CO2.
How does the flow rate stop CO2 rebreathing? Can you visualize that?
Sure. Think about a simple mask covering the nose and mouth. When the patient exhales, their breath, containing CO2, fills the space inside the mask. If the fresh oxygen flowing into the mask is too low, say only 2 or 3 liters per minute, it doesn't provide enough volume to completely flush out all that exhaled gas before the patient takes their next breath in. So they end up re-inhaling some of their own CO2.
Okay.
But if you have a higher flow rate, let's say 6, 8, or 10 liters per minute, as this protocol implies, with 5 malmonins, that continuous strong inflow of fresh oxygen effectively washes out the exhaled CO2 through the exhalation ports on the side of the mask. It ensures that the patient is primarily inhaling the high concentration oxygen you intend to deliver and minimizes the risk of them building up CO2 in their blood, which we call hypercapnia. It keeps the air inside the mask fresh.
It's like constantly flushing that mask space clean with fresh oxygen.
That's a great way to put it. Okay, let's test this concept then. A patient is prescribed 40% oxygen via mask at 5 liters per minute preoperatively, but the nurse taking over accidentally sets the flow meter to only 2 liters per minute using a standard simple mask. What's the main clinical concern with this incorrect setup?
Based on what you just said, the main concern would be, well, 2 things really. First, they're probably not actually getting 40% oxygen because the flow is too low to meet their inspiratory demand. But maybe more importantly, they're likely rebreathing their own exhaled carbon dioxide because the low flow isn't flushing the mask. So the big concerns are inadequate pre-oxygenation, meaning a smaller oxygen reservoir, and the risk of hypercapnia.
Absolutely. Spot on. You've got it. Inadequate preoxygenation reduces that vital safety buffer during induction, and the CO2 rebreathing can lead to respiratory acidosis and other issues. Both are significant problems stemming from that incorrect low flow rate.
Okay, point 4.3. Assess vital signs every 60 minutes. Blood pressure, heart rate, respiratory rate, SpO2, temperature. This seems like standard monitoring, but the hourly frequency is specified.
Yes, hourly vital signs monitoring in this immediate preoperative period provides a dynamic assessment of the patient's physiological status as they get closer to surgery. A single set of vitals taken on admission is just a snapshot in time. Checking them hourly allows the clinical team on the ward to track trends and, crucially, detect any changes, subtle or significant, that might indicate a developing problem or could affect the patient's readiness for the procedure.
What specifically are you monitoring for with each of those vital signs in this context?
Okay, let's take them one by one. Blood pressure is key. Many vascular patients have underlying hypertension. Is it adequately controlled? Or are they becoming hypotensive, perhaps due to fasting, anxiety, or medications? Heart rate is monitored for tachycardia, maybe indicating stress, pain, or low blood volume, or for bradycardia or the development of new arrhythmias, which are common in this group. Respiratory rate and SpO2, oxygen saturation, assess their pulmonary function and how well they're oxygenating, which is vital given the pre-oxygenation step and their underlying risks. And temperature screens for fever, which could signal an underlying infection. An unexpected fever might even be grounds to postpone an elective surgery. Any significant deviation from the patient's baseline or expected values needs prompt escalation to the medical team, including the surgeon and anesthetist.
Are there sort of general thresholds that would typically trigger concern and require that escalation?
Yeah, while individual patient baselines always matter and trends are often more informative than single readings, there are general thresholds that usually warrant attention. For example, significant new hypertension, maybe a systolic pressure consistently over 180 mmHg, or hypotension, perhaps a systolic below 90 mmHg depending on their usual level. New onset arrhythmias like atrial fibrillation or uncontrolled rapid heart rates, say consistently over 100 or 120 beats per minute at rest. Respiratory rate falling below maybe 10 breaths per minute or climbing above 25. SpO2 persistently dropping below their target range despite the supplemental oxygen. Or a temperature spiking above 38 degrees Celsius, 100.4 Fahrenheit. The hourly checks provide the crucial opportunity to identify these acute changes or concerning trends promptly before the patient gets to theater.
Okay. Now, point 4.4 is marked critical in the protocol. Critical. Do not apply a blood pressure cuff or do venipuncture on the affected limb. This is a very specific and clearly very important instruction for vascular surgery patients. Why is this so critical?
This instruction is absolutely paramount. It's uniquely relevant to a limb that has pre-existing vascular disease and is the target of the planned surgical intervention. It really boils down to, as we touched on briefly before, protecting the patient's pathway, that is, the limb itself and its vessels that the surgeon needs to work on. Let's break down why each part of that instruction, no blood pressure cuff, no venipuncture, is so critical.
Okay, let's start with the blood pressure cuff. Why not use it on the affected limb?
Applying a blood pressure cuff and inflating it on a limb that already has significant arterial stenosis, meaning narrowing or generally reduced blood flow, can actually be harmful.
Harmful how?
Well, imagine squeezing a garden hose that's already partially blocked or kinked. The external pressure from the inflated cuff can further compromise or even temporarily completely occlude the already precarious blood flow down to the tissues of that limb. In a limb that might be experiencing critical ischemia, lack of blood flow, even a brief period of further reduced flow from a BP cuff could potentially worsen the tissue state right before surgery. It can also be quite painful for the patient if the limb is already ischemic. And there's a theoretical risk, though probably small, of dislodging plaque or damaging already fragile, diseased vessels with the pressure. Furthermore, the surgeon often assesses the limb's perfusion status, the pulses, the capillary refill, the temperature just before the procedure. Applying a cuff could artificially alter that immediate preoperative assessment.
So the key reason is preventing any further compromise to an already vulnerable blood supply in the target limb.
Precisely. Protect the flow. Now, venipuncture, that's inserting a needle into a vein, usually for drawing blood samples or inserting an intravenous line on the affected limb, is equally critical to avoid for several important reasons.
Okay, what are the risks associated with venipuncture on that limb?
Firstly, and perhaps most obviously, there's the risk of hematoma formation. Any attempt at sticking a needle into a vein carries a risk of causing some bleeding under the skin, leading to bruising or a collection of blood called a hematoma. On a limb where the surgeon is planning to make incisions and perform detailed dissection, perhaps to expose arteries or harvest veins, a significant hematoma can be a real nuisance. It can obscure the normal anatomical landmarks, making the surgery technically more difficult, potentially prolonging the operation, or even slightly increasing risks.
So it literally gets in the surgeon's way, potentially.
It can, yes. Secondly, and this is very important specifically in vascular surgery, you risk damaging veins that might be needed as conduits for bypass grafting. The patient's own long saphenous vein running up the length of the leg is frequently the surgeon's first choice for creating a bypass around a blocked artery in that leg. Careless or multiple venipuncture attempts in the leg or foot could potentially damage or cause inflammation in segments of this crucial vein, rendering them unsuitable for use as a graft. You could inadvertently be damaging the surgeon's essential building material for the repair.
Ah, okay, so you might actually ruin a critical part of the planned reconstruction without realizing it.
Exactly. It's a major reason to avoid venipuncture there. Additionally, any break in the skin from a needle stick creates a potential entry point for bacteria. Doing this on the limb planned for surgery theoretically increases the risk, even if slightly, of surgical site infection, especially if the puncture site is near the planned incision. And lastly, it just adds unnecessary discomfort or pain to a limb that might already be symptomatic due to poor circulation.
This is such a specific and clearly critical point for anyone caring for vascular patients preoperatively. Let's reinforce that mnemonic you suggested earlier. Protect the patient's pathway. It reminds staff to keep that surgical field, the affected limb, clear of interference and keep the blood flow as undisturbed as possible.
Protect the patient's pathway. I think that captures it well. It emphasizes that the affected limb isn't just any limb. It's the surgical target, the pathway for intervention, and it needs special handling to preserve its status, its potential graft material, and the clarity of the surgical field.
Let's use that scenario with the new nurse again to really illustrate this. A new nurse comes onto the ward, understandably wants to get the vital signs done, and prepares to put a standard BP cuff on the patient's left leg, which is the leg scheduled for surgery. They also plan to draw the admission bloods from a vein in the left forearm. What's the immediate correct action and the essential explanation?
The immediate action is to intervene politely but firmly right away before the cuff is inflated or the needle is used. Stop them and explain the critical instruction from this unit's protocol. For vascular surgery planned on a specific limb, we never put a blood pressure cuff or perform venipuncture on that affected limb. Then, you need to redirect them clearly to use the unaffected limb for all these procedures, the other arm for the BP cuff, the other arm or hand for the IV, and blood draws.
And the explanation.
Keep it clear and concise, focusing on the why. Explain the key risks. Putting a cuff on this leg could potentially harm the blood flow, which is already compromised, and drawing blood or putting an IV here could cause bruising that makes the surgery harder for Dr. Weir, or it might damage a vein that the surgeon needs to use for the actual bypass graft. It needs to be communicated very clearly and decisively because of how critical this point is for patient safety and surgical success in this specialty.
That point really drives home the spiralized nature of this vascular surgery protocol. Okay, moving on. Point 4.5. Do preoperative assessment, including a preoperative ECG.
Right. This refers to the comprehensive assessment typically performed by the ward team, often the nursing staff, sometimes junior doctors as well, before the patient is cleared to go to the operating theater. It's more than just vital signs. It involves reviewing the patient's overall condition, confirming their medical history and any current symptoms, double-checking that all the required preoperative checks and investigations, like those blood tests we discussed, are completed, reviewed, and documented appropriately.
Okay.
It also includes verifying their NPO status again, assessing their mobility and general functional status, and importantly, addressing any immediate question or concerns the patient might have just before surgery. It's essentially a final systems check of the patient's readiness and optimization from the ward perspective.
And why the specific instruction to include a preoperative electrocardiogram, an ECG?
Because, as we've alluded to, patients needing vascular surgery have a very high prevalence of underlying coronary artery disease. Atherosclerosis, the hardening of the arteries, is usually a systemic process. It affects blood vessels throughout the body, including the heart arteries. This significantly increases their risk of having perioperative cardiac events, things like a heart attack, myocardial infarction, or serious heart rhythm problems, arrhythmias, around the time of surgery.
So the ECG is a screening tool for that cardiac risk.
Exactly. A preoperative 12-lead ECG is a quick, non-invasive, and relatively inexpensive screening tool. It assesses their underlying cardiac rhythm and looks for specific signs that might indicate increased risk. We look for evidence of resting ischemia, like ST segment depression or T wave inversion, which might suggest parts of the heart muscle aren't getting enough oxygen even at rest. We look for Q waves, which can indicate a previous, perhaps silent heart attack. And we look for any significant arrhythmias like atrial fibrillation or conduction delays like heart block that could complicate anesthetic management or the postoperative course.
If something unexpected or new is found on that preoperative ECG, does that automatically mean the elective surgery gets canceled?
Not necessarily canceled, no, but it absolutely mandates action and careful consideration. Finding new, potentially significant changes, like those new Q waves suggesting a recent infarct, or marked ST depression suggesting active ischemia, or maybe new onset rapid atrial fibrillation, requires immediate consultation. The findings need to be discussed urgently with the anesthetic team and potentially with a cardiologist.
What might happen then?
It could lead to several outcomes. Perhaps adjustments in the anesthetic plan are needed, maybe opting for more intensive intraoperative cardiac monitoring. It might influence the choice of postoperative destination, maybe leaning towards HCU or ICU, even for a seemingly moderate procedure. Or if the findings suggest a very unstable cardiac situation or a very recent event, yes, it could very well lead to the postponement of the elective surgery to allow for further cardiac assessment, investigation, and optimization first. You wouldn't want to proceed with elective surgery on someone potentially having an acute cardiac issue. So the ECG serves as a vital part of that preoperative cardiac risk assessment, specifically targeting the known vulnerability of this vascular patient population.
So key things to look for on that ECG printout, described simply, would be signs of old damage like Q waves, signs the heart muscle might not be getting enough blood flow even at rest, like ST depression, or a fast, irregular rhythm like atrial fibrillation. Those are the main red flags from this screening test.
That's a good summary of the key concerns, yes. Identifying those potential underlying issues before anesthesia is the primary goal of mandating this pre-op ECG.
Okay. Point 4.6. Insert an intravenous line and initiate 0.9% ACL at 60 millibletes, 80 millibletes if weight more than 100 kilograms. This sounds like standard procedure, getting IV access and starting some fluids.
Yes, inserting an intravenous line, or cannula, is a fundamental preoperative step. It provides absolutely essential access for several reasons. It's needed for administering fluid hydration while the patient is NPO. It's the route for giving any preoperative medications that might be ordered, like antibiotics or anxiety medication. Critically, it's how the anesthetic agents are given during induction and often for maintenance of anesthesia. And importantly, it provides rapid access for emergency medications should any issues arise during surgery or anesthesia. You need that reliable IV access established before things get started.
And the fluid choice here is 0.9% sodium chloride, often called normal saline. Why this specific fluid?
0.9% sodium chloride is an isotonic crystalloid solution. What that means is its salt concentration, its tonicity, is similar to that of human blood plasma. Because of this, it tends to stay within the vascular compartment reasonably well, at least initially, compared to more hypertonic solutions. It's the most common type of intravenous fluid used for basic maintenance hydration when a patient is NPO, helping to maintain their intravascular volume and prevent dehydration without causing major shifts in electrolytes, assuming kidney function is adequate.
And what about the specific rates mentioned? 60 millimeters per hour or 80 milliliters per hour for patients over 100 kilograms. How are those rates determined?
These are fairly standard maintenance fluid rates. They're designed to provide enough fluid to meet the body's basic metabolic needs and replace insensible losses, like from breathing and skin, during the fasting period, but without giving excessive fluid, which could lead to fluid overload. Fluid overload can be particularly detrimental in patients with underlying heart failure or kidney problems, which are common in this population.
Is there a calculation behind it?
There are standard formulas for estimating maintenance fluid needs, like the 4-2-1 rule, which estimates hourly needs based on weight. For a typical 60-70 kilogram adult, that rule might suggest around 100 millihour. This protocol uses 60 millihour for standard patients, which is a bit more conservative, perhaps around 1 millikilohour for a 60 kilogram person. For patients over 100 kilograms, the 80 millihour rate is slightly higher, acknowledging their larger body size and fluid requirements, but it's still relatively conservative, less than 1 millibaric hour based on their total weight. This suggests a deliberate strategy to prevent dehydration while being very cautious about avoiding preoperative fluid overload.
So the goal is tailored basic hydration enough to ensure they aren't significantly volume depleted heading into surgery. which is important for maintaining blood pressure stability, especially when anesthetic drugs cause vasodilation, but not so much that it strains their cardiovascular system.
Precisely. Maintaining adequate intravascular volume helps the cardiovascular system tolerate those hemodynamic shifts that often occur during the induction of anesthesia.
Okay, point 4.7. Assess and document any patient allergies. Example, iodine, antibiotics. Now, this feels like a safety check that should have happened much earlier, perhaps at an initial hospital admission or in the clinic. Why is it listed again here in the immediate pre-op preparation phase?
You're right, allergy assessment should absolutely happen earlier, but including it here, again on the preoperative checklist, is a critical safety double check, or maybe even a triple check. Even if allergies were noted previously in the patient's record, actively reiterating the assessment and documenting it prominently right before they go to theater ensures that this absolutely vital information is confirmed, front of mind, and immediately available to the entire team involved in their care at this critical juncture: the ward nurses, the anesthetists, the surgeons.
And the timing is important because they're about to be exposed to potential triggers.
Exactly. In the perioperative period, patients are potentially exposed to a whole range of substances they might be allergic to. Anesthetic drugs themselves, muscle relaxants, prophylactic antibiotics given just before incision, skin preparation solutions which often contain iodine or chlorhexidine, latex in gloves or equipment, potentially contrast agents if imaging is used.
And missing a significant allergy at this stage could have severe consequences.
Potentially life-threatening consequences, yes. Anaphylaxis, a severe allergic reaction, can happen rapidly and be fatal. So explicitly asking the patient again, do you have any allergies to medications, foods, latex, tapes, contrast dyes, anything at all? And ensuring this is clearly and visibly documented, often with bright red allergy bands or prominent alerts in electronic health records, acts as a crucial final safety barrier before any potentially triggering substances are administered. The protocol specifically highlights iodine and antibiotics because iodine might be used in skin prep or contrast, and antibiotics are very commonly given prophylactically for surgery.
Okay, a vital safety redundancy check. Point 4.8 is similar. Assess and document current medication, e.g. anticoagulants, antiplatelets.
Yeah.
Again, confirming the medication list right before surgery.
Yes, and for the same fundamental reasons: safety and accurate, up-to-the-minute preoperative planning. Having a confirmed, completely accurate list of all the medications the patient is currently taking, prescription, over-the-counter, herbal supplements, everything is absolutely essential information for both the surgical team and the anesthesia team.
And the examples given, anticoagulants and antiplatelets, are particularly critical in vascular surgery.
Extremely critical. Anticoagulants like warfarin or the direct oral anticoagulants, DOACs like rivaroxaban, apixaban, and antiplatelet agents like aspirin, clopidogrel, ticagrelor are highlighted because they directly interfere with the body's clotting mechanisms. They fundamentally impact the patient's coagulation status and therefore their risk of bleeding during and after the operation.
Operating on blood vessels when a patient is actively taking these medications introduces a significant risk of bleeding.
It absolutely does. These medications are designed to inhibit clot formation, which is often necessary for treating or preventing other conditions like atrial fibrillation or coronary artery disease. But that same effect dramatically increases the risk of uncontrolled hemorrhage when you're surgically cutting and suturing blood vessels. While the plan for managing these crucial medications, preoperatively deciding whether to hold them for how long, if bridging therapy with something like heparin is needed, is typically made well before admission day.
So the plan is made, but this is about confirming compliance.
Exactly. Confirming on the day of surgery what the patient has actually taken or not taken is vital. Did they remember to hold their warfarin? Did they take their aspirin this morning when they shouldn't have? Misunderstandings happen. So you need to confirm the reality of their medication intake right before they go. And it's not just about bleeding risk meds. Other medications like antihypertensives, beta blockers, ACE inhibitors, diabetes medications, insulin, oral agents, or steroids all have important implications for anesthetic management, blood pressure control, glucose control, and the patient's physiological response to the stress of surgery.
So this is really the final definitive check to confirm the patient's current medication profile and understand its potential impact on the immediate operative plan and anesthetic management.
Yes, the surgeon needs to know, the anesthetist absolutely needs to know, and the nursing staff managing them pre- and post-op need this confirmed information to proceed safely.
Point 4.9.
Yeah.
Administer any preoperative medication as prescribed by anesthetist.
Right. This instruction serves as a reminder to the ward staff. They need to specifically check the patient's medication chart or orders for any preoperative medications, often called pre-megs, that have been prescribed by the anesthesia team. And importantly, they need to administer them at the correct time before the patient is called to theater. These medications aren't usually standard protocol for everyone. They're specifically tailored to the individual patient based on the anesthetist's assessment and the planned anesthetic technique.
What kind of tailored medications might be prescribed as pre-meds?
Common examples include medications to reduce anxiety, known as anxiolytics, often a small dose of a benzodiazepine like midazolam or diazepam, given perhaps an hour before surgery. They might prescribe drugs to reduce the risk of aspiration by decreasing stomach acid production, like ranitidine or omeprazole, or reducing stomach volume or speeding up gastric emptying, like metoclopramide, especially if the patient is considered higher risk. Sometimes the first dose of prophylactic antibiotics is ordered by the anesthetist to be given on the ward shortly before transfer, although often it's given in the theater itself. The key is that these are prescribed specifically for that patient, and giving them at the right time ensures they have taken effect by the time the patient arrives in the operating room.
Okay, point 4. Leno. Only order blood for transfusion if specifically requested by Dr. Weir, for example, aorta aneurysm surgery. This seems to go against the old practice of ordering blood for almost everyone having major surgery, just in case.
Yes, this point reflects a more modern, proactive, but also judicious approach to the use of blood products. Ordering blood for transfusion specifically, requesting the blood bank to perform a cross-match where they physically test the patient's blood against specific donor units and reserve those units involves significant logistical effort for the blood bank staff. And blood products themselves are a precious resource with a limited shelf life. Furthermore, transfusion, while absolutely life-saving when necessary, is not without risks. There are potential risks of transfusion reaction, from minor febrile reactions to severe hemolytic reactions, volume overload, and although very rare now with rigorous screening, a theoretical risk of infectious disease transmission.
So the default here is not to cross-match blood unless significant blood loss is genuinely anticipated.
Precisely. This protocol puts the responsibility for that decision and the specific request squarely with the operating surgeon, Dr. Weir in this case. The protocol anticipates when this is likely by giving the example of aorta aneurysm surgery. Major aortic procedures, especially open repairs rather than endovascular ones, inherently carry a higher potential for significant blood loss compared to many peripheral vascular operations, just due to the size and pressure within the vessel being operated on, even with meticulous surgical technique.
So for those known high-risk procedures, the surgeon proactively requests blood to be cross-matched and ready.
Correct. They anticipate the potential need. For many other lower-risk elective vascular cases, like perhaps a straightforward carotid endarterectomy or maybe some types of peripheral bypass, the surgeon might instead rely on a group and save or type and screen. This means the blood bank determines the patient's blood group, ABO and Rh type, and screens their plasma for any unexpected antibodies that could react with donor blood. No specific units are cross-matched or reserved, but having this information allows for compatible blood to be provided much more quickly from the blood bank inventory if an unexpected need arises during surgery compared to starting from scratch.
So this approach balances being prepared for likely high-loss scenarios with avoiding the routine cross-matching and reserving of blood products and their associated costs and logistical burdens for lower-risk procedures.
Exactly. It's a risk-stratified approach to preoperative blood product management, conserving resources while ensuring timely availability when the clinical prediction indicates a higher likelihood of need.
Okay, point 4.11. Keep the patient as still and comfortable as possible. A simple instruction, but presumably clinically important.
Yes, it sounds basic, but it supports both the patient's physiological state and their psychological well-being as they wait for surgery. Keeping the patient comfortable, ensuring they're not in pain, positioned comfortably in bed helps to reduce anxiety. Promoting stillness, discouraging unnecessary movement, can help conserve energy and oxygen consumption. This might seem minor, but in patients with limited cardiopulmonary reserve, minimizing oxygen demand is actually beneficial. It also practically reduces the risk of falls or other injuries in an unfamiliar hospital environment, especially if they've received sedative premedication.
So the overall aim is for the patient to arrive in the operating theater as calm, rested, and physiologically stable as possible.
Exactly. It's just a component of good fundamental nursing care that contributes to a smoother and safer transition to the operating room.
Point 4.12. Request the patient to remove dentures, jewelry, and contact lenses. This sounds like pretty standard pre-op removal of personal items.
Yes. These items are routinely removed before any surgery requiring general anesthesia or significant sedation for very specific safety reasons. Dentures, whether full or partial, can become loose or dislodged during anesthetic induction when the airway is being managed, or even during emergence. If they fall to the back of the throat, they can cause a critical airway obstruction. So they absolutely must be removed beforehand and stored safely, usually labeled in a denture pot.
Airway safety is clearly paramount there. What about jewelry?
Jewelry, especially metal jewelry like rings, necklaces, earrings, needs to be removed primarily because of the risk of burns associated with diathermy or electrocautery. That's the electrical instrument surgeons frequently use to cut tissue and seal bleeding blood vessels. The electrical current passes through the patient's body to a grounding pad. If the patient is wearing metal jewelry, the current can potentially arc or concentrate at the point of contact between the metal and the skin, causing a nasty thermal burn. It's also generally a security risk for valuable items in the operating theater environment. So, all jewelry should ideally be removed and given to family or secured according to the hospital's policy.
Okay, diathermy burn, risk and security, and contact lenses.
Contact lenses, both hard and soft, can cause significant problems during anesthesia. When a patient is under general anesthesia, their eyes are often taped shut, tear production is reduced, and the normal blinking reflex is absent. Contact lenses left in place under these conditions can dry out, stick to the cornea, and cause painful corneal abrasions or even infections. It's much safer for them to be removed beforehand. Glasses are also typically removed for similar reasons: comfort during positioning, avoiding breakage, and allowing access to the eyes if needed.
So these are all standard but essential pre-anesthesia safety checks that are just incorporated explicitly into this vascular protocol.
Yes, they are fundamental safety checks to ensure the patient is clear of personal items that could potentially cause harm or interfere with procedures in the operating room environment.
Point 4.13. Please request the patient to shower with chlorhexidine soap if time allows, sponge bath if unable to shower. This is about preoperative skin preparation on the ward.
Correct. This is a really key evidence-based measure aimed at preventing surgical site infections, SSIs. We know that the patient's own skin bacteria are the most common source of microbes that cause infections in surgical wounds. The goal of preoperative skin cleansing with an antiseptic agent like chlorhexidine gluconate, CHG, is to significantly reduce the bacterial load, the number of bacteria living on the skin surface, before the patient even gets to the operating room, where the surgical site will be prepped again much more intensely right before the incision.
How does chlorhexidine work, and why is it often preferred over, say, just regular soap?
Chlorhexidine is a potent broad-spectrum antiseptic. It works by disrupting the cell membranes of bacteria, effectively killing them or inhibiting their growth. It works against a wide range of bacteria, including nasty ones like MRSA, and also has activity against yeasts and some viruses. A key advantage of chlorhexidine over simple soap is its property of substantivity or remanence. Yes, it means that chlorhexidine actually binds to the proteins in the outer layer of the skin, the stratum corneum, and continues to exert its antimicrobial activity for several hours after it's applied and rinsed off. Regular soap cleans the skin but doesn't have that persistent killing effect. The protocol mentions, if time allows, for a full shower with chlorhexidine soap, because that's the ideal method. It covers a large surface area. However, it recognizes that might not always be feasible. If time is short before surgery, or if the patient is unable to shower due to mobility issues or illness, then performing a targeted sponge bath using chlorhexidine impregnated wipes or solution, focusing particularly on the area around the planned surgical site, provides a crucial alternative way to achieve a significant reduction in skin bacterial load.
And you mentioned this is evidence-based. Is there strong evidence supporting chlorhexidine bathing for reducing surgical site infection?
Yes, absolutely. The use of preoperative skin preparation with chlorhexidine is widely supported by numerous clinical studies and is recommended in major international guidelines for SSI prevention. The evidence generally shows that it significantly reduces the rates of surgical site infections compared to using non-antiseptic soap, or sometimes even compared to other antiseptics like povidone iodine wash, depending on the specific context and study. It's often considered a Class 1 or Class 2A recommendation in guidelines, meaning there's good evidence supporting its use.
Okay, a key infection control measure, point 4.14. Provide the patient with the appropriate theater attire. Seems like a simple logistical step.
It is simple but necessary. It just ensures the patient is changed out of their own clothes or standard hospital pajamas and dressed appropriately for entering the controlled, clean environment of the operating theater complex. This typically means putting on a clean hospital gown, often opening at the back, a disposable cap to cover their hair and prevent shedding, and sometimes disposable booties or footwear covers. It's a small step contributing to maintaining the overall cleanliness and reducing particle shedding within the theater environment.
Makes sense. Point 4.15. Request the patient or a family member to complete the pre-anesthetic form.
Yes, this pre-anesthetic assessment form or questionnaire is a really vital document, primarily for the anesthetist who will be looking after the patient. It's designed to systematically gather essential information that informs the anesthetic plan and risk assessment. It typically covers the patient's detailed medical history, cardiac, respiratory, renal, neurological conditions, etc., any previous surgeries, and crucially, any previous anesthetic experiences, particularly asking about any problems like difficult airway management, prolonged waking up, severe nausea or vomiting, or any known or suspected family history of adverse reactions to anesthesia, like malignant hyperthermia. It will also reconfirm the comprehensive list of current medications and allergies, reinforcing those previous checks we talked about, and often asks about lifestyle factors like smoking history, alcohol consumption, or recreational drug use, all of which can influence anesthesia. This completed form is a critical tool for the anesthetist when they perform their own preoperative evaluation, allowing them to formulate the safest and most appropriate anesthetic plan tailored specifically to that individual patient's health status and history.
And why does it specify patient or a family member?
Because, realistically, the patient themselves may not always be the most reliable historian on the day of surgery. They might be anxious, in pain, perhaps already feeling the effects of illness or premedication, or they might have cognitive issues or simply not remember details accurately. In many cases, a close family member who knows the patient well can provide a much more complete and accurate medical history, especially regarding past events, long-term conditions, or any family history of anesthetic problems. The goal is to get the best possible information into the hands of the anesthetist, so involving the most reliable informant, whether that's the patient, a family member, or sometimes both, is crucial.
Okay. Point 4.16. Request the patient to sign the hospital permission form and a family member to sign as witness. This sounds like administrative paperwork.
It generally is, yes. This is typically related to the patient's formal admission to the hospital facility itself, rather than the specific surgical procedure. It usually covers things like consent for general medical treatment while hospitalized, agreement to the hospital's terms of service and financial policies, maybe acknowledgments regarding privacy practices like HIPAA in the U.S. or equivalent regulations elsewhere. It's standard administrative procedure for most hospitalizations.
And how is this different from the consent form for the actual surgery?
It's quite distinct. The consent for the specific surgical procedure is a separate, crucial process. That involves the operating surgeon having a detailed discussion with the patient and family, if appropriate, explaining the planned operation, why it's needed, the potential benefits, the significant risks and possible complications involved, any alternative treatment options, and answering all the patient's questions. The patient then signs that specific surgical consent form to indicate they understand and agree to undergo that particular procedure. That discussion and signing process typically happens earlier, maybe in the surgeon's clinic days or weeks before, or sometimes during a dedicated pre-admission assessment visit. The hospital permission form mentioned here is much broader, covering the general terms of their hospital stay. Having a family member sign as a witness simply adds an administrative layer of verification that the patient appeared to sign the form willingly.
Okay. Administrative versus procedural consent. Got it. Now, the final point of this section, 4.17. Confirm which procedures to be done on what site. Compare this with the patient, family, and theater list. This feels like another one of those final, absolutely critical safety checks before they leave the ward.
It is absolutely vital. You're right, this is one of the very last opportunities for the ward team to catch a potential error before the patient physically enters the operating theater suite. It's a key component of what's often called the universal protocol for preventing wrong site, wrong procedure, wrong person surgery. It serves as a crucial precursor to the more formal surgical timeout or final verification that will be performed again by the entire team inside the operating room just before the incision is made. The goal here on the ward is to ensure there is complete alignment and agreement among everyone involved regarding three key things. Who is this patient? What exact procedure are they having done? And where on the body? Which side, which level, which structure is it going to be performed?
And why specifically involve the patient and the family again in this final ward confirmation?
Their active involvement is essential because they represent the source of truth regarding their understanding of the planned procedure. By asking the patient directly if they are able to participate and confirming with the family, you are actively ensuring that their understanding matches the documented plan. You then compare this information rigorously against the official operating theater list or schedule for the day. This verifies that the patient being prepared on the ward matches the patient scheduled for surgery in the correct theater for the correct procedure on the correct side or site. This three-way check patient-family understanding versus the consent form notes versus the official theater list is an incredibly powerful safety mechanism designed specifically to prevent those devastating wrong patient, wrong procedure, or wrong site surgical errors.
It really is a final triple check just before handover. What the patient and family understand, cross-referenced against the surgical plan documents, cross-referenced against the official theater schedule.
Precisely. You can picture the nurse or doctor doing it verbally. Okay, Mr. Davis, just confirming one last time before you go. You're here today for the operation on your right foot, is that correct? And Mrs. Davis, you agree. Okay. And I'm checking here against the theater list, and it confirms. Mr. Robert Davis, Theater 15, right foot amputation. This final verbal and documentation check, often combined with visually confirming any preoperative site marking that the surgeon should have placed on the limb, serves as that critical final safety barrier before the patient leaves the relative safety of the ward environment.
That covers an incredibly extensive and detailed patient preparation phase. It's clear how much goes into getting a patient ready safely. Let's do a quick micro recap of this large Section 4.
Good idea. There was a lot in there.
Okay, Section 4 detailed the crucial steps in preparing the patient for surgery. Key points included strict MPO status from admission to prevent aspiration risk, pre-oxygenation with a 40% mask at adequate flow to build an oxygen reservoir, hourly vital signs monitoring to track trends and detect instability, the critical instructions specific to vascular surgery, no BP cuffs or venipuncture on the affected limb to protect blood flow and potential grafts, performing a thorough preoperative assessment including a screening ECG due to high cardiac risk, establishing 4V access and starting maintenance fluids cautiously, conducting final safety checks for allergies and current medications, especially anticoagulants, antiplatelets, administering any prescribed pre-meds, only ordering cross-matched blood if specifically requested by the surgeon for high-risk cases, ensuring patient comfort and stillness, removing dentures, jewelry, and contacts for safety, performing preoperative skin cleansing with chlorhexidine to reduce infection risk, providing theater attire, ensuring administrative forms like the pre-anesthetic questionnaire and hospital permission are completed. And finally, performing that vital three-way confirmation of the correct patient, procedure, and site involving the patient, family, and theater list before leaving the ward.
An excellent summary. It really covers the gamut from major physiological preparation and risk mitigation through to critical safety checks and basic comfort measures, all aimed at getting the patient to theater in the best possible condition.
Now let's look at the final section, Section 5, Theater. This outlines the transition to the operating complex and the initial post-procedure plans. Point 5.1. The family are encouraged to accompany the patient to the entrance of the theater complex.
Yes, this point nicely continues that theme of patient and family-centered care that we saw with the initial welcome. That transition period, moving from the relative familiarity of the ward down the corridors towards the often intimidating environment of the operating theater suite, can be a moment of particularly heightened anxiety both for the patient and for their waiting family members. Allowing family members to walk alongside the patient, perhaps holding their hand, as far as the designated entrance to the theater complex provides invaluable psychological support and comfort during this potentially stressful separation.
It lets them stay connected until the very last possible moment before the patient enters that restricted clinical environment.
Exactly. It acknowledges the importance of that family presence. It also provides a final, brief opportunity for any last-minute words of reassurance, or perhaps a quick question for the accompanying ward staff before the final goodbyes are said. It just aims to make that transition feel a little less clinical and more humane.
Okay. Point 5.2. The procedure will be done in Theater 15. A very specific logistical detail included in the protocol.
Yes, including the specific theater number provides clear, unambiguous logistical direction. It ensures that the staff transporting the patient know exactly where they are going within the potentially large and confusing operating theater complex, and it ensures the receiving team in Theater 15 are expecting this specific patient. It helps prevent delays or confusion during handover. It might also possibly imply that Theater 15 is specifically equipped or perhaps preferentially designated for vascular surgical procedures in this hospital, maybe housing necessary specialized equipment like fixed intraoperative imaging systems, C-arms, specialized vascular instrument sets, or staff familiar with these types of cases.
So clear directions for smooth logistics and potentially indicating a specialized space set up for this kind of work. Point 5.3. After the procedure, the patient will be transferred to the cardiac HCU, ICU, or back to Ward 9. This outlines the potential post-operative destinations.
Correct. This point acknowledges that the level of care required after vascular surgery varies depending on the complexity of the procedure performed and, very importantly, the patient's individual risk profile, their comorbidities, and overall physiological state. The decision on where the patient will go immediately after they leave the post-anesthesia recovery area is typically made before the surgery even starts, usually in consultation between the surgeon and the anesthetist based on these factors.
Okay, let's break down those options mentioned. Cardiac HCU, that's a high care unit. What kind of patient goes there?
Yes. A high care unit, sometimes called a step-down unit or intermediate care unit, provides a level of monitoring and nursing care that's higher than a standard surgical ward, but less intensive than a full intensive care unit, ICU. Patients sent to HCU typically require more frequent observation than standard ward patients, perhaps needing continuous ECG monitoring, more frequent vital signs, closer management of intravenous fluids or certain infusions like low-dose vasoactive drugs, or more intensive respiratory support like high-flow nasal oxygen, but they don't require invasive monitoring like arterial lines or central venous lines or mechanical ventilation support that would necessitate ICU. Many patients after moderate to major vascular surgery might be appropriate for HCU, either because of their underlying cardiac risk factors or due to the potential for postoperative hemodynamic instability, fluid shifts, or the need for very vigilant observation of the surgical site perfusion, even if the procedure itself went smoothly.
Okay, so intermediate care for higher risk patients or procedures. And the ICU, intensive care unit.
The intensive care unit is reserved for the most complex surgical cases or the most physiologically unstable or critically ill patients. In the context of this protocol, this would typically include patients who have undergone very major procedures, like open repair of an aortic aneurysm, as mentioned earlier, is high risk for bleeding. It would also include patients with significant pre-existing organ failure, severe heart failure, respiratory failure requiring ongoing support, or significant kidney failure. These patients often require invasive monitoring, like arterial lines for continuous blood pressure monitoring, central lines for measuring pressures and giving strong drugs, mechanical ventilation to support breathing, or complex pharmacological support with multiple infusions to maintain blood pressure or heart function. The ICU provides the highest ratio of nurses to patients, the most advanced monitoring capabilities, and immediate access to the full spectrum of organ support technologies.
And the third option mentioned, back to Ward 9, implies that's the standard surgical ward setting for these patients.
Yes, Ward 9 is presumably the designated standard inpatient surgical ward for vascular patients in this hospital. This would be the appropriate destination for patients who have undergone less complex or lower risk vascular procedures, or those patients who have minimal comorbidities and are expected to recover relatively smoothly with standard postoperative nursing care. This would include things like monitoring vital signs routinely, managing pain, checking the surgical wound and limb perfusion, and helping with mobilization as appropriate for standard ward care.
So this point essentially sets the expectation that the patient's immediate postoperative level of care is carefully planned and stratified based on their individual needs and the magnitude of the surgical intervention they've undergone.
Exactly. It's part of planning the patient's entire journey through the hospital stay, ensuring the level of care resources provided matches their anticipated clinical requirements after surgery.
And the final point in this section, 5.4. The family members are welcome to wait in the waiting area adjacent to the theater complex, where Dr. Weir will communicate with them after the procedure. This addresses the postoperative communication plan.
Yes, and this is incredibly important for managing family anxiety during what can often feel like a very long and stressful waiting period while their loved one is undergoing surgery. Designating a specific waiting area, ideally one located conveniently adjacent to the theater complex, provides a clear place for family members to gather. But the crucial part of this instruction is stating explicitly that the surgeon, Dr. Weir, will personally come to that specific location to speak with them and provide an update after the procedure is finished.
That sets clear expectations.
It does. It tells the family exactly where they need to be and reassures them about who they will hear from and roughly when, i.e., after the procedure. This significantly reduces the uncertainty and stress of waiting, wondering when or if they'll get news. It provides reassurance that there is a structured plan for the surgeon to communicate the outcome and the patient's immediate condition as soon as they are able after completing the operation and ensuring the patient is stable.
It really formalizes that critical postoperative feedback loop between the surgical team and the patient's anxious family.
Exactly. It demonstrates a commitment to comprehensive, patient, and family-centered care, extending beyond just the technical aspects of the surgery itself.
Okay, let's do a quick micro recap of Section 5. This section covered the final steps related to the theater phase. It highlighted the importance of family support, encouraging them to accompany the patient to the theater entrance. It specified the exact theater location for logistical clarity. It outlined the planned postoperative destinations, cardiac HCU, ICU, or the standard Ward 9, based on procedure complexity and patient risk. And critically, it established a clear plan for the surgeon to communicate directly with the family in a designated waiting area after the surgery is complete.
A good summary of the transition and immediate post-op planning phase.
Finally, before we wrap up the core content, the source document makes specific mention of other related protocols. It says, please also refer to the general postoperative protocol and blood pressure monitoring protocol. And also, a specific postoperative protocol relevant to the patient's procedure will be attached to the patient's postoperative prescription chart. And lastly, a specific discharge protocol and script for home medication will be given directly to the patient at discharge. What's the significance of mentioning these other documents?
These references are important because they contextualize the submission protocol. They frame it not as a standalone document operating in isolation, but as one integral part of a much larger interconnected system of care protocols, presumably used within this specific vascular unit or hospital. The mention of a general postoperative protocol suggests there are standardized approaches to common aspects of care after any surgery, like maybe basic pain management principles, DVT prophylaxis, etc. The specific blood pressure monitoring protocol indicates a detailed, standardized approach just for managing blood pressure postoperatively, which is obviously critical in vascular patients.
So it emphasizes that care is guided by protocols throughout the entire patient journey, not just on admission.
Precisely. It shows a commitment to standardizing care across phases. Furthermore, the mention of a procedure-specific postoperative protocol being attached to the patient's chart is particularly key. This highlights an even greater level of granularity and tailoring in their approach to standardizing care. It explicitly recognizes that the postoperative management for, say, a patient who's had a femoral popliteal bypass, requiring frequent pulse checks in the foot, specific positioning perhaps, is quite different from the needs of a patient who's had a carotid endarterectomy, where neurological observations and neck hematoma checks are paramount. These procedure-specific instructions ensure that the nursing staff on the ward have readily available, tailored guidance for the monitoring, mobilization, specific checks, and potential complications relevant to the actual operation that was performed.
That provides a sort of customized standard care pathway for each major procedure type.
Yes, that's a good way to put it. And finally, the mention of a specific discharge protocol and the provision of a script for home medication shows that this structured, protocol-driven approach extends all the way through the patient's stay, right up to planning for their safe transition back home. The discharge protocol would likely cover essential information like wound care instructions, advice on activity levels and limitations, warning signs of complications to watch out for, and details of follow-up appointments. Providing the medication script directly ensures clarity on ongoing treatment.
So, taken together, these references paint a picture of a comprehensive, planned, and structured pathway covering the entire patient journey from the moment they are admitted, through the preoperative preparation, the surgery itself, the tailored postoperative care phase, and all the way to a planned and informed discharge.
Exactly. It strongly underscores the unit's commitment to providing standardized, safe, evidence-based, and comprehensive care delivery across the entire episode of hospitalization for their elective vascular surgery patients. It's about systemizing best practice.
That was an incredibly thorough exploration of this admission protocol. It really highlights, doesn't it, the sheer density of clinical rationale, risk mitigation strategies, safety checks, and accumulated experience that's embedded in almost every single line item of such a document.
It's fascinating, I agree. When you break it down like this, you see how a document that might initially look like just a checklist is actually a highly sophisticated distillation of complex clinical principles and critical safety requirements, all carefully tailored to the specific needs and risks of the elective vascular surgery patient population.
Okay, let's try and synthesize this with maybe an end-of-core content mega recap to pull it all together.
Let's do it.
We started with the absolute necessity of robust patient identity confirmation using multiple methods, coupled with a welcoming approach to build trust and reduce anxiety right at the start.
The foundation, safety and compassion.
Then we moved into preoperative assessments. Routine blood tests established that crucial baseline physiological status: blood counts, kidneys, liver, electrolytes, glucose, coagulation flagging risks early. And specialized investigations like chest X-ray or advanced angiography are used judiciously, only on specific request by the surgeon for immediate pre-op planning needs, assuming the main workup is done.
Minimum data set plus targeted extras if needed.
Then came the extensive patient preparation phase. Strict NPO status to prevent aspiration, pre-oxygenation to build that safety buffer, hourly vital signs for dynamic monitoring, and that critical directive, unique to vascular surgery. Absolutely no BP cuffs or venipuncture on the affected limb to protect blood flow and potential grafts.
Protect the patient's pathway. Can't emphasize that enough.
Absolutely. Then establishing 5E access and careful maintenance fluid administration. Rigorous final checks on allergies and current medications, especially those affecting bleeding. Administering any specific anesthetist-prescribed pre-meds. Ordering blood products only when high loss is anticipated, like in aortic surgery. Ensuring patient comfort. Removing hazardous personal items like dentures and jewelry, performing evidence-based chlorhexidine skin prep for infection control, getting them into theater attire, and finally, that vital three-way confirmation of patient, procedure, and site involving the patient, family, and theater list before leaving the ward.
A comprehensive safety net woven through the preparation phase.
And lastly, the transition to theater. Encouraging family presence for support, clear logistics with a specific theater number, planned postoperative destinations, HCU, ICU, or ward, based on risk, and a structured plan for surgeon-family communication afterwards. Plus, the acknowledgement that this fits into a wider system of post-op and discharge protocols.
Covering the entire continuum of care.
So looking back, the protocol really embodies key principles: patient safety at every step, identity site confirmation, allergen checks, proactive risk mitigation, NPO, pre-oxygenation, limb protection, blood management, efficient logistics, theater designation, post-op planning, robust infection control, chlorhexidine, and consistent patient and family-centered care. Welcome, communication, presence.
It's a comprehensive guide designed to ensure a standardized, safe, and effective process for every patient undergoing elective vascular surgery in that unit.
It really is. Now, thinking about this for you, our listener, how does dissecting a specific detailed protocol like this one actually inform our own understanding of best practices, perhaps in our own varied clinical environments, and maybe the importance of adhering to detail, even when things get busy?
That's a great point. Seeing the why behind each step reinforces its importance. It moves it from a tick box exercise to understanding the potential consequences of omission. And what's also fascinating, I think, is how the specific details embedded within this protocol, things like the exact oxygen flow rate chosen, or the precise IV fluid rate, or the threshold for ordering blood, reflect both universal evidence-based principles of care and potentially institution-specific or even surgeon-specific refinements. These might be based on local experience, available resources, or common patient characteristics seen in that particular unit.
Which brings us to a final thought, perhaps something for you to consider in your own practice. How do you, as a clinician, navigate that balance? The balance between the necessary adherence to robust, standardized protocols like this one, which are designed for safety and consistency, and the equally important need for critical thinking and individualizing care based on a specific patient's unique presentation, their comorbidities, or unexpected findings. There are times when sound clinical judgment might suggest that a slight deviation from the protocol is warranted for that particular patient. How do you navigate that inherent tension between standardization for population safety and flexibility for individual needs?
That balance, that judgment call, that's really where the art meets the science in clinical practice, isn't it?
It truly is. A great thought to leave you with as you reflect on this deep dive. Thank you so much for joining us today.
It's been my pleasure. A fascinating protocol to dissect.
Until next time, keep diving deep into the knowledge.